But once again, welcome to another episode of the 1NF webinar series. And today we'll be having discussion around the topic intracranial meningiomas. The presenters are Dr. Golo and Dr. Wabueze, and they are both from the Memphis Hospital for Neurosurgery in Enugu, Nigeria. They'll be treating us today to a robust discussion on the topic. We thank our
I'm sorry, it appears Dr. Jalemi has dropped out of the meeting, not button, possibly as a result of network challenges, I suppose. But I'm certain he'll be back with us shortly. While we wait for him to return, we recognize the presence of our father, Emeritus Professor Samuel Odeblan. Welcome, Prof. Our senior faculty of the day, Professor Timothy Ibudi, is also here with us. Welcome, Prof. That will be introduced better give us.
Okay, apologies for that. I don't know if. Okay, I guess I was lost. Yeah, over to the presenters, please, so we don't waste.
Good evening, our teachers and senior colleagues. So today we'll be anchoring the discussion on intracranial meningiomas, and I'll be talking on the spectrum and pathophysiology, and my colleague will be talking on the clinical features, principles of resection, and management. Okay, so this is the outline that we would be making use of. Yeah, so by way of introduction, the term meningioma was coined just over 100 years ago by very popular neurosurgeon, Harvey Cushing. And like we mostly know, it's a group of mostly benign, slow-growing tumors that mostly derive from the arachnoid cap cells. And just very few of them compared to the benign ones are atypical and anaplastic. It's also the commonest primary intracranial tumor, accounting for about 20 to 30% of all primary intracranial tumors. And of course, of all the intracranial tumors, it's the most histologically diversified tumor. And in terms of epidemiology, it accounts for about 98% of all CNS tumors, the other 2% being accounted for by spinal meningiomas. And it's commoner in females globally, with an incidence of about 2 to 3, with a ratio of about 2 to 3 to 1 female to male ratio. And in terms of the age, as the age increases, the trend is that the incidence also increases. But in children, we tend to find out that a lot of these meningiomas tend to be infratentorial and a lot of them syndromic and multiple. The peak age for the incidence is about the fourth decade of life. And then for reasons that are not still clear, meningiomas tend to be commoner in African Americans and Blacks compared to Caucasians. And studies or multiple literature have shown that about 50% of patients with NF2 have at least a component of meningioma, and about 8% of these turn out to be multiple. The etiology of meningiomas are largely unknown. However, there are some risk factors that have been attributed to this. And the female sex hormones play a very prominent role in terms of the risk of development of meningiomas. It's been shown that use of oral contraceptives and hormone replacement therapy significantly increases the risk for the development and growth of the tumor. And it's also been noted that patients with meningioma, for patients with meningioma, the growth rate tends to increase during pregnancy. And this has been attributed to hormone receptors, which also subserves these tumors. And then it's been found out that somatostatin receptors type 2 are seen in about 100% of patients with meningioma, and as high as 88% for progesterone receptors. And it's also very important to note that for patients that have receptor positive meningiomas, they tend to have a much milder WHO grade, that's grade 1 compared to higher grades. Ionizing radiation exposure has been confirmed to be the only environmental risk factor that increases the risk for meningioma. And it's also been shown that for patients that develop meningioma from exposure to radiation, most of these meningiomas tend to be more aggressive and tend to be multiple and have a high risk of recurrence. And they also tend to occur in younger patients. And the risk is also dose dependent. And it also occurs for patients that are exposed to both high and low dose irradiation. And several literatures have been awash with this. The very classic example is that of Japan during the Second World War, Hiroshima and Nagasaki experience. And the literatures have also shown that children that were treated with irradiation for tinea capitis tend to come down with this condition several years later. Obesity has also been associated with increased risk for meningioma by its increased expression of insulin-like growth factor 1, most importantly, as well as adipokine expression. Insulin-like growth factor 1 is known to be a highly anti-apoptotic agent, which enhances tumor development and growth. And then very commonly, there are some familial syndromes which have been associated with meningioma, developments of meningioma. The commonest, which we are aware of, is neurofibromatosis type 2, which results from mutation in the NF2 gene, which results in which encodes for the production of schwannomin protein located on chromosome 22. And this is usually acquired in an autosomal dominant fashion, like we all know. And a lot of these patients that have this NF2 that develop meningiomas eventually, usually have multiple meningiomas. A classic example is the Miss-Me syndrome. So patients with BRCA1 associated protein 1 have also been shown to have an increased risk for meningiomas, and that accounts for why a lot of patients with breast cancer also tend to come down with meningiomas. there's increased expression of estrogen and progesterone receptors in these patients. A lot of some other familial syndromes like the Cowden syndrome have also been associated with this Liefeld-Meni von Hippel-Lindau syndrome. I don't really have time to go into that. And of course, there's been some inconclusive risk factors that have been historically associated with the development of meningioma. Curiously, the use of headphones at some point in time was believed to be a risk factor for meningioma, but studies have largely been inconclusive in that line. Also, viral infections and occupational hazards. Studies in this respect have also been quite inconclusive. The etiopathogenesis of meningioma actually has its foundation in genetic alterations, which result from one or more of the etiologic factors which were mentioned. And this results in one or more of several genetic alterations which we see. Most commonly is inactivation of tumor suppressor genes via the very common two-hit hypothesis. Tumor suppressor genes, like we know, have recessive alleles. And so for it to have 100% penetrance, and there has to be involvement of at least two alleles. Oncogenes have dominant alleles. So alteration in just one of the alleles can result in all this. So once this happens, there'll be development of abnormal tumor cells from the arachnoid cap cells, and progression and growth is dependent on a number of factors. Most importantly, the amplification and overactivation of vascular endothelial growth factors, which have accounted for, which also accounts for why some meningiomas would have peritumoral edema compared to their size, as well as activation of the inflammatory cascade. I've talked about most of the immunogenetics. So these are some of the genetic alterations that eventually lead, and chromosomal aberrations that eventually lead to the development and growth of meningiomas. And each WHO grades, the 3 WHO grades, like we'll see subsequently, have common genetic and chromosomal abnormalities to them. And then they also have some unique aberrations that occur. NF2 mutation can occur in any of the 3 phases. So the preoperative classification of meningiomas, basically on the basis of the location, meningiomas can be supratentorial, infra, or intraventricular. More commonly, we see them at the convexities, parasagittal region. They could also be meningiomas around the cavernous sinus and foramen magnum. We'll get to talk about all that later on. This is just a study from a Western population, which identified parasagittal meningiomas as the commonest meningiomas that were seen, closely followed by convexity and tuberculum sella. And then coming down to our center, a study that was done by Professors Mezwe and Uhegulam, a retrospective study that was carried out over 6 years, carried out on 52 histologically diagnosed patients. It was discovered that within this region, olfactory groove meningiomas tend to be the commonest meningiomas that are seen, closely followed by convexity meningiomas, in contrast to what was seen in the Western population. And then the male to female ratio just marginally different, with the females just marginally edging it out. A ratio of 1 to 1.8, 1.08 male to female ratio. So these are just MRI images. This is a convexity meningioma. And then this is a parasagittal meningioma. It takes its origin from the falls. And basically, it can be classified into three on the basis of its location around the superior sagittal sinus. Middle third parasagittal meningiomas are usually the commonest with an incidence of about 37 to 70%. And it's also important to note the implication for tumor detection and resection. For instance, for most middle third meningiomas within the dominant hemisphere, a small tumor might end up being symptomatic, while those in the anterior posterior might have to grow to a larger extent. And then the anatomical configuration of these sinuses, the caliber tend to increase from anterior to posterior, and then they tend to have more drainage within the middle aspect of the middle third of the sagittal sinus. So the implication in terms of resection, in terms of ligation and preoperative preparation, it's quite important. We'll get to talk about that subsequently. This is just a single, the general classification for parasagittal meningiomas. The commonest is that of the single classification, which was developed way back in 2006. Classification system that we usually use commonly, in contrast to the Brocci classification, which was developed in 2003. And it's quite important to differentiate between convexity and parasagittal, and then parasagittal and parafalcian meningioma. Okay, in parasagittal meningiomas, these take their origin from the falls, and then it tends to grow outwardly, radially, compressing the brain from that particular angle, like we can see here. Okay, and then in the convexity meningiomas, it's attached to the convexities of the brain with an intervening normal brain parenchyma. And then we'll look at parafalcian meningiomas attached to the falx with an intervening normal brain tissue between it and the sinus. These are just examples. Sphenoid wing meningiomas classified on the basis of their morphology into plaque and nodular. Cushing and Essenhard subclassified the globoid or the nodular type into the medial sphenoid wing, the middle, and then the lateral or the pteronia, which we are familiar with. Okay. The latest WHO grading system for meningiomas was developed in 2001. And very key important factors that were considered for this grading system include the mitotic index, the presence or absence of brain invasion, and most importantly, molecular diagnosis, especially for the very aggressive grades. That's the grade 3. We'll get to see that subsequently. So for the WHO grade 1, they are generally non-aggressive. This is the commonest, accounting for about 85 to 95%. And then the key histology features that are seen in this grade that would, in such tumors that would make one think of a low grade or a grade 1 includes that of a mitotic index of less than 4 in 10 consecutive high power fields. Of course, there'll be absence of brain invasion, and then also absence of any other criteria that qualifies for grades 2 or grades 3, which we'll get to see subsequently. A lot of people have argued that the Ki-67 and MIB1 indices, are usually hospital dependent and so are not really reliable. But generally, Ki-67 index that is less than 5% is most likely points towards a grade 1 meningioma. And according to the WHO classification grading, There are about 9 subsets that fall under this grade 1, with the meningothelial meningioma being the commonest. So this is a typical histologic feature. There are other features that are seen, but when one sees this, it's a huge pointer towards a grade 1 meningioma. A walling pattern, which is typically seen in meningothelial grade, and psammoma bodies, which can be seen in fibroblastic or psammomatous meningiomas. And the meningothelial meningiomas are the commonest, like we've talked about. The classic histologic features that are seen, the walling pattern, like you can see here. Once you see that walling pattern, predominantly within the cells, it's a huge pointer to the meningothelial meningioma. Of course, there could also be a sheet-like pattern, but these are quite uncommon. Angiomatous meningiomas account for 2.1% of all these variants. And the key distinguishing factor is the fact that these are very highly vascular grades of meningiomas. And of course, it can be confused for other grades as well as other tumors, such as microcystic and fibroblastic meningiomas. It can also be confused for intraaxial hemangioblastomas. But one key thing that stands it out from other forms of meningiomas is the fact that the vascular component must be greater than 50% of the total tumor areas. And then, of course, on brain imaging, MRI, we see the typical features for meningiomas: extraaxial, broad-based dural lesion with dural tail, as well as intervening CSF cleft. So this can also contrast it from hemangioblastomas, because both of them are associated with peritumoral edema, as well as avid contrast enhancement. So the angiomatous meningiomas they have 2 subsets, microvascular and macrovascular, which are displayed here. And microcystic meningiomas, they are typically identified by the presence of extracellular microcysts, which contain pale eosinophilic mucinous fluids. And it's important to note that this can also occur in synchrony with angiomatous variants. And they could also have associated peritumoral edema and variable degrees of vascularity. Now, the fibroblastic type, they present as, with the presence of sheets, a spindle-like pattern, and this is quite important because it can help to distinguish fibroblastic from meningothelial meningiomas, which typically present with that wall-like pattern. And then psammoma bodies could often be present. Transitional meningiomas lie at the point between meningothelial and fibroblastic. So we tend to see a mixture of these two histologic grades, the walling pattern as well as the spindle-shaped pattern of the fibroblastic. And then it's the commonest variant that is seen with NF2. So these are other histologic grades. And for the immunohistochemistry, like you mentioned earlier on, somatostatin receptor 2 are usually quite specific for these meningiomas. They are positive in 100%. Epithelial membrane antigen and progesterone receptors are also positive stains that could be seen. And then of key importance is the absence of glial fibrillary proteins, GFAP, usually negative because of the absence of invasion in these very low grade meningiomas. WHO grade 2, also known as atypical meningioma, characterized by the presence of, histologically now, of mitotic index of 4 to 19 per 10 consecutive high power fields, presence of brain invasion, and then the presence of clear or chordoid histology, or the presence of 3 or of 5 of the following features which I've listed out. And then it's quite important that it has a 10-year survival rate and 10-year recurrence rate that lies at the borderline between the benign and the anaplastic, which we'll see subsequently. And the KI index, 67 index, usually lies between 5 to 10%. And also very important, unlike the grade 1, which tends to be commoner in females, as you get towards the more aggressive grades, it becomes more predominant in males. So for grade 2, you have slightly equal female to male ratio. Now, as you get to grade 3, you have predominance in males. So this is just an example, a chordoid meningioma, a grade 2, characterized by the presence of trabecula, these cord-like projections, which are pathognomonic for the chordoid meningiomas. And immunohistochemistry shows positive epithelial membrane antigen, as well as podoplanin and focal cytokeratin occasionally, and is negative for GFAP. And this is that for the clear cell, usually patternless arrangement, disorganized arrangements, which usually do not display any typical features associated with meningiomas. So for the grade 3, this is where a lot of changes were made by the WHO in the 2021 classification. So unlike previous classifications that either identified that graded meningioma as grade 3 by the presence of either papillary or rhabdoid features or the presence of anaplastic features, a molecular diagnosis plays a key role, much like in the classification for the new classification for astrocytic tumors. So there must be at least a third promoter mutation as well as homozygous deletion of cyclin-dependent kinase inhibitors, 2A, most importantly. In addition to the presence of more than 20 mitotic index of more than 20 per 10 high power fields. And then, of course, the features of cellular anaplasia. And of course, these are the most aggressive. There can be metastasis, even though it's quite rare. And then the Ki-67 index is usually greater than 20%. Like we mentioned earlier on, it's predominantly seen in males compared to females. The 10-year survival rate is quite abysmal at 14 to 34%, and the recurrence rate is about 100%. So these are just because of this. And then these are molecular studies. We've talked about some of them. The natural history and prognosis. The natural history falls into one of two categories. It's either the meningioma does not undergo any growth, in other words, it remains stable. And this is seen in about 30 to 35% of patients, or it might undergo some form of growth. And then when it does that, it can either grow exponentially in about 25% of patients, or the growth might be slow at a rate of about 2 to 4 millimeters per year in 75% of patients. And then, of course, metastasis also it can occur, it's quite rare. Commonest sites are typically to the lungs in about 60% of patients, as well as the pleura, the bone, liver, and kidneys. All right, thank you.
All right.
Thank you very much, Dr. Okolo.
Yes. So
Hello?
standing on. Hello, sir.
Okay, you can go on.
Okay. Standing on the existing protocol, we're heading towards the clinical features of meningioma. Already established by the previous speaker, the fact that this is a very slow-growing tumor, and then the clinical features we tend to appreciate is usually corroborated with the location and then its effect on the adjacent brain structures that it's compressing. Several studies have tried to put different rates at which abbreviated various values at which the growth rates can be measured, being 1 cm per cube for some studies, greater than 15% for other studies. But this highlights the fact that the presentation of the patients tend to be influenced by the growth, the effect these tumors tend to have on some parts of the brain. With the tumors that are known, for example, the olfactory groove meningioma, which are found in eloquent areas tend to present much later because they tend not to they don't have imagined clinical features, as against those that comprehend the optic apparatus or the cerebellum, where you have florid signs coming up very early on. Also leaning into this previous work that's been done by our teachers, we found out that our own cohort of patients here did not fall into we had olfactory groove meningioma being the highest form of being the larger form of meningiomas that we saw in our own cohort, and then convexity and parasagittal in that order. Like I've said, meningiomas their presentation tend to be non-specific. Its location and the compression of adjacent tissues tend to influence it. The prominent features that we tend to see here are headache, focal cranial nerve deficit, seizures, cognitive change, weakness, vertigo, and the likes. In our own cohort of patients for this for the self-studies, similar pattern was noticed with headache and seizures taking a large chunk of the presentation for our patients. Breaking down the clinical features into the various fossa, the compartments, intracranial compartment. For the anterior cranial fossa, where we have the parasagittal, the facile, olfactory groove, and tuberculum cell meningioma, headache, anosmia, seizures, and psychomotor personality disorders are prominent features that are appreciated, which each of those meningioma having some characteristic feature. For example, the olfactory groove meningioma, which we know the Foster-Kennedy syndrome. Anosmia is also there for that category. For the middle cranial fossa stroke, the sellar suprasellar region, where the optic chiasm is present, visual impairment tends to be one of them, tends to be a commonly seen presentation in this category of patients. The closeness of of the meningioma to the hypothalamus and then the diencephalon apparatus means that most of them will come down with hormonal changes, and these have to be these are known presenting complaints for this category of patients. Petroclival meningiomas, because of their closeness to the upper cranial nerves, could lead to upper cranial nerve neuropathies. Clinodal meningiomas are notorious for having visual impairment because of the adjacent nature of them to the optic nerve, and then exothermos could result from a possible orbit infiltration. For the posterior cranial fossa, the cerebellopontine angle, where we have the facial nerve as well as the cranial nerve, those middle cranial nerves also, you can have facial pain being a major complaint, and then hearing loss also as part of the complaints the patient may come up with. For cerebellar convexity, those florid cerebellar signs may be part of the presenting complaint. Foramen magnum meningioma, one of their prominent features is that of migrating hemiparesis, where the patient presents with ipsilateral upper limb weakness that migrates then to the ipsilateral lower limb, then to the contralateral lower limb, and then the contralateral upper limb in that order. This is one of the unique features of foramen magnum meningioma, in addition to the occipital headache that is seen. The tentorial meningiomas, because of their closeness to the ventricles, could also present with features suggestive of obstructive hydrocephalus, so raised intracranial pressure in the form of headache. Vomiting could also be a presentation for this category of patients. The peritorcular meningioma, because of their adjacent nature to the occipital lobe, could also present with visual field defects. In terms of differential diagnosis for this condition, the differential diagnosis can be appreciated based on the various key features which we see in meningiomas. Hyperostosis, the hyperostosis, fibrous dysplasia, Paget's disease, other dural masses too, which hemangioperiocytoma, which is now referred to as solitary fibrous tumor. In terms of location, there are different forms of presentation. There were acoustic schwannomas are going to present in the cerebellopontine angle, and then others have been listed here. In working up this patient, the diagnostic radiology is a very key component of the workup, where the brain CT, brain MRI, and MRV, and digital subtraction and angiography, there are key radiographic methods of working up this patient. Highlighted here are some of the key features you find in the radiology of meningioma. With the first slide, with the first picture, depicting the spoke wheel appearance or the sunburst appearance, which is which we are appreciating this first in the CT here, depicting the radicular nature of the feeders, which the arterial feeders that the meningiomas tend to recruit as they grow. This in the MRI here is a little bit more drives home the point of this sunburst appearance. With the CTA at the end, also depicting one of the factors there, which is the mother-in-law sign, where there's an early arterial, early blush in the arterial phase, and there which still persists into the venous phase, which is a prominent sign that you find in meningiomas. Also highlighted here from the radiology is that of dural tail. Dural tail, however, is not pathognomonic for meningiomas, as other conditions such as solitary fibrous tumor, glioblastoma, primary CNS lymphoma are known to also have dural tails also. However, speculation about what can be attributed for dural tails for the dural tail include the theories there are that of one, the presence of infiltration of the dura by the neoplastic cells, the reaction, tissue reaction to the presence of tumor, and not necessarily the presence of tumor cells. Also highlighted in the next slide is the CSF cleft, which can appreciate on this brain CT, which is this hypodensity that surrounds the space occupying lesion we can see here, with associated edema here, which follows the white matter fibers. On this last slide indicated here is hypostosis, which tend to get similar explanation as that of the dural tail. Also, as part of workup for diagnostic workup for meningiomas, we may want to brain CT is also important for as part of our workup to delineate when these meningiomas are in adjacent, close to prominent blood vessels. Olfactory groove meningiomas are known to displace the anterior cerebral arteries superiorly, and knowing the intimate relationship between these meningiomas and the arterial feeders is quite important in surgical planning. Here I highlighted 3 MRIs for depicting MRI features of meningioma. Here we can appreciate the hyperintensity around this lesion. This denotes CSF cleft also, which is a prominent feature and it suggests the extra-axial nature that meningiomas are known to have. Here we have edema well highlighted. Just to draw attention also, on T2 sequence of MRI, we can also to a very good extent predict the nature of the meningioma, as meningiomas that are known to be hyper intense on T2 have been known to be soft, they are in soft in consistency and known to be vascular, as against those which are seen to be hypo intense on T2, which are known to be of a harder nature. So those things could also influence surgical planning. Delineated here are the various examples of meningioma. Here we have a convexity meningioma, by definition, a meningioma that is situated on a lobe without involvement of the skull base or adjacent sinus. Here, this denotes a parietal convexity meningioma here. Here we have a parasagittal meningioma in the posterior third. Of course, already highlighted by the previous speaker, its division into three different parts, both anterior, middle, and posterior. Also important when discussing about posterior third parasagittal meningioma is their relationship to the sagittal sinus, where Sindhu's classification gives us that whether between type 1 to type 6, all influencing our surgical planning and decision. Facile meningioma here depicted, where the major point here is that they tend to have an intervening brain parenchyma between them and the falls, as against parasagittal, where you have no intervening brain parenchyma. Olfactory groove meningioma here depicted on this slide. Prominent to highlight on this slide is these flow voids we can appreciate superiorly, which are the anterior cerebral artery, which has been displaced. These tend to influence approach. Closely related to olfactory groove meningioma, tuberculum cell meningioma, because they tend to have common, they are very adjacent areas of origin. This can be differentiated by the fact that the site of origin for olfactory groove meningioma is from the frontosphenoid suture as against the tuberculum cellular, where you have it coming out from the planus sphenoidale area, as well as the limbus sphenoidale area. The main blood supply for the olfactory groove, the meningioma could be from both anterior and posterior ethmoidal, unlike in tuberculum cellular, where you have the posterior ethmoidal. Then their relationship to the optic apparatus is a very important point to differentiate them, with the olfactory groove tending to depress the optic apparatus, while tuberculum cellular does elevate the optic apparatus. Sphenoid wing meningiomas are also well depicted in this MRI, where they are classified into the medial, the middle, and lateral. Also highlighted here is the hypostosis that accompanies this tumor. Clinoidal meningioma, of course, can actually appreciate their intimate relationship here with the optic nerve, particularly on this right side, where there's an asymmetric distribution in this particular. Cavernous sinus meningiomas are also an entity that is known. What's unique about them is that the cavernous sinus is known to be a very treacherous area in the brain, where surgical adventure or misadventure into that area is not advised because of the critical structures that are present. And so this is one category of meningioma where other forms of adjuncts are advocated instead of surgical excision. Highlighted here on this CTA is we can appreciate that on the cavernous portion of ICAA, there's obvious narrowing, which this cavernous meningioma has done. Petroclival meningioma is another very important meningioma that which we know that this region of the brain is another very difficult area to assess. It's usually associated with the cranial nerve neuropathies, and oftentimes multiple approaches have to be utilized to assess petroclival meningioma. Also not spared are the ventricles. The ventricles are known to still harbor meningiomas, both in the lateral ventricle, and in this other slide, we velum interposition, which is also close to the pineal region. Then those are still known to harbor meningiomas. Also, the foramen magnum meningioma, this is another entity which must be aware of. They broadly can be classified based on their relationship with the dentate ligament, with some being anterior, like we can appreciate from this sagittal MRI. Here we have an anterolateral compression, a left-sided anterolateral compression, which we can appreciate here. Now, in terms of management, what are the management options for our patients? The major options for us are, number one, the wait and see approach. And this is usually done when there's a small asymptomatic meningioma, and then the patient has a short life expectancy and no follow-up. And patients who are known to have multiple comorbidities that are not fit for surgical management, a wait and see approach can also be advocated. For symptomatic meningiomas, however, surgery is the mainstay for managing this patient. Surgery could be in the form of open surgery or minimal invasive surgery. For the WHO grade 1 tumors, after a gross total resection, they can get straight follow-up, while for those with subtotal resection, radiotherapy can be utilized. For the WHO grade 2, after gross total resection, follow-up can also be done. While for the WHO grade 3, irrespective of the Simpson grade of resection, those patients are supposed to get radiotherapy and possibly chemotherapy follow-up. In terms of preparing these patients for surgery, what are the modalities? Preparing these patients for surgery is multimodal and multidisciplinary approach for the medical evaluation of this patient. And what we want to do is that we want to be able to quantify their risk, do risk assessment, do complete workup to assess the effect of the lesion on them, and then implement strategy to reduce perioperative complications. So this can be in the form of course, the cardiac evaluation. Also prominent to be highlighted here is that oftentimes, depending on the location of this meningioma, other specialties like the ophthalmologist, the ENT surgeon, as well as endocrinologists may need to be invited to optimize or assess our patients prior to our intervention. Of course, our normal laboratory workup checks will be done for the patient, full blood count, electrolyte coagulation profile, but also to highlight here are the endocrine investigations that have to be done, especially for those meningiomas that have endocrine disturbances. Of course, cortisol, prolactin, hair function tests, all this will need to be optimized prior to surgical intervention for patients. Of course, before surgery is done, patients are usually placed on seizure prophylaxis. Steroid administration is also given because these tumors are known to be accompanied by widespread edema, and this would make surgery much easy for resection. Perioperative autologous and designated blood donation may need to be done because for those meningiomas that have close relationship to the sinus and those meningiomas that are known to be highly vascularized, there will be need to arrange for the strategy for blood replacement in this patient because these tumors are known to bleed. They are known to bleed a lot. Preoperative embolization is also an important concept in the workup of this patient, as some tumors that can benefit from embolization and thus shrinkage of the tumor prior to surgery should be given that opportunity. However, the drawback of embolization is that, especially for the olfactory groove meningioma, part of the complication following this could possibly be blindness. What are the principles of surgical management? The principle basically is that we want to, is usually based on the type of meningioma that we are addressing. The craniotomy and the approach is tailored to the location of the meningioma. We want to remove as much bone as is necessary to allow us enough space for resection. We want to respect arachnoid plane. We tend to preserve, repair, and reconstruct vessels with meticulous care. Also, part of your surgical principles of planning is that of what you intend to do with the hypostotic bone, as well as the dura that will be excised. What are your plans for, what are your options for duroplasty in the patient? Highlighted here is the various surgical approaches that can be used for meningioma depending on the location. Of course, we can see a myriad of approaches, be it terrenal, be it zygomatic, subtemporal, transpetosa, retrosigmoid, suboccipital, bilateral, all depending on the type of, on the location of the meningioma, as well as other characteristics that would have been determined pre-op. For positioning, of course, being that meningiomas can occur in any part of the, basically all parts of the brain, the positioning of patient can either be, we can benefit from either from all the various positions that can be utilized in neurosurgery. For supine being electively preferred for convective meningiomas. For lateral position, the sphenoid wing and temporal lobe meningiomas. Prone for the posterior fossa meningiomas, prone position tend to be well preferred. Then for sitting position, this slide is just also depicting the use of minimal invasive methods for addressing meningiomas here. It's important. It's important to make reference of this fact because for those who have the, is it from here? It's not from. Okay, from I don't know what's happening to the screen. It's not from here. Okay. I don't know what's happening to the screen. Okay, it's not from here. I don't know what's happening to the screen. Okay, for the various surgical approaches for converting meningioma, craniotomy can be done for frontal, parietal, and temporal type. For sphenoid wing, we have terminal orbitozygomatic. For posterior fossa, we have suboccipital transmastoid approaches. Endoscopic approaches can also be utilized in those who have the competence and the who have mastered the learning curve required to excise this meningioma. Despite the different approaches that can be utilized for meningiomas, a common theme is that of the 4Ds, which involved devascularization, detachment, debulking, and dissection as a method of approach of these tumors. In the study that was done in our own in our practice environment, the commonest approach that was favored for the olfactory meningioma was actually subfrontal, constituting 57.1%, and interhemispheric constituting 42.9%. Now, with respect to how much is done during surgery, the Simpson grading is the benchmark to determine how much we do. And we have from Simpson grade 1 to Simpson grade 5 with the accompanying recurrence rate, when there's macroscopic complete tumor removal with excision of dura, and then the involved bone is also removed. This gives us the lowest resection, the lowest recurrence rate of 9%. Other concepts of a grade 0 Simpson resection are advocated by Professor Amefti, where he talks about giving up to a 2 cm free margin is also one of the ideas in the literature. What do you plan to do with the bony defects that may occur? For small defects, you may want to replace do primary bone closure, cranioplasty, which can involve use of mesh or MMA, methylmercuric acrylate, can also be utilized with their various advantages and disadvantages clearly spelled out. For larger defects that are greater than 5 cm, we will want to utilize cranioplasty instead. For the dura defects, you may want to do a primary dura closure, or you can get from pericranial grafts to utilize. The other options we have includes the use of dura graft as well as dermal grafts also, with their other advantages clearly spelled out. With respect to complications, complication, of course, differs across the board depending on the type of meningioma, with the parasagittal meningioma being notorious for having hemorrhage. Seizures are also known to occur. For sphenoid meningiomas, visual defects and facial numbness. Posterior fossa meningiomas are known to be associated with inadvertent injury sometimes to the lower cranial nerve, presenting as dysphagia, dysatria, or bulbar or pseudobulbar palsy. For the cerebellopontine angle based meningioma, hearing loss could also be a complication. Now, what are the adjuncts that are available to us for use? And this is basically radiotherapy. The indication could be meningiomas that are not amenable to curative resection, malignant meningiomas, who we know would have a high rate of recurrence, meningiomas for which the risk of a complete resection, essentially like the optic nerve sheath meningiomas, where it is unwise to aim for a gross total resection. Those category of patients, you want to electively go for a subtotal resection and then utilize adjuncts in managing this patient. In conclusion, meningiomas are slow-growing tumors that occur in any part of the intracranial cavity. Their presentation is affected by their rate of growth and their compressive effect on the adjacent tissue. Their management is essentially surgical, but other modalities can be indicated depending on the condition. Thank you very much.
Thank you very much, Dr. Wabeze, for keeping to time and for that robust discussion. I guess the time is up for the floor to be open. But before we grant the floor open, I want to welcome our faculty for today, Professor T.O. Odebode. Permit me to give an abridged version of his citation. Professor Timothy Olugbenga Odebode, a retired neurosurgery professor from the University of Ilorin and consultant neurosurgeon at the University of Ilorin Teaching Hospital, Nigeria, boasts a distinguished career marked by significant contributions to his field. With an extensive educational background, including a BSc Hons, MD-CHB, Fellows of the National Postgraduate Medical College of Nigeria, the West African College of Nigeria, International College of Surgeons, American College of Surgeons, and Fellow of the National Academy of Medicine, and also MD for National Postgraduate Medical College of Nigeria and Certificate in Advanced Neurosurgery from Japan. He has left a lasting impact on medical education and practice. Born in Balogun, Nigeria, 70 years ago, Prof's academic journey began at St. John's Anglican Primary School, Ayorumbo Village, before excelling at the Awe High School and Government College in Ibadan. He pursued medicine at the University of Ife and earned numerous accolades, including a national scholarship for academic excellence. Following his National Youth Service, Prof pursued advanced leadership training in Singapore and clinical attachment in the United Kingdom. He obtained fellowships in general surgery and neurosurgery from the prestigious Nigerian Postgraduate Medical College of Nigeria and the West African College of Surgeons, respectively. Prof's career highlights include pioneering neurosurgical services in Kwara State and neighboring states of Nigeria, serving as head of the Division of Neurosurgery from the year 2000 to date, head of Department of Surgery from the year 2007 to 2009, and later as a professor of surgery, specialty neurosurgery at the University of Ilorin from 2009 to date. He has led groundbreaking research projects, notably the MRC Crash 1 and 2 studies, and invented patented medical devices like the Odebode Agaja cervical traction device and electrically powered striker frame, earning recognition at national research fairs. A prolific author with 70 publications, Prof holds editorial roles in prominent medical journals like the Journal of Clinical and Applied Neurosciences, Tropical Journal of Health Sciences, and the Journal of Surgery and Surgical Sciences. He contributes as a reviewer and examiner for the postgraduate medical institutions. He furthered his expertise through clinical fellowships in Japan and the United States of America. Outside of medicine, Prof is ordained as a reverend and is married to Professor Stella Olushola, a distinguished academic in agricultural extension and rural development. Their union has been blessed with children and grandchildren. Throughout his career, Professor Timothy Olugbenga Odebode has demonstrated exemplary leadership, scholarship, and innovation in the field of neurosurgery, leaving an indelible mark on the medical practice and education in Nigeria and beyond. Dear participants, senior colleagues, and senior faculty here present, permit me to welcome Professor T.O. Odebode to the floor. Prof, you're welcome, sir. And thank you, sir, for coming.
Thank you. Good evening to everyone.
Good evening, Prof.
Good evening. I have listened to the two previous presenters. They have done a good job to the topic already. I will just have one or two comments to what they have said or clarify some points. The first one I want to mention is related to the age group of presentation of meningiomas. Yes, in the Caucasians, they said that the peak incidence is between 70 to 85, 90. But it looks as if in Africa, the peak incidence is at a lower age group, maybe 50 to 60 or 40 to 60. In our own paper on intracranial meningiomas, we found that there was a variation in the age incidence. There were two peaks. One was before the age of 20, and the second peak was between 40 and 60. So, that age peaks also was related to some changes in in the sex ratio. We found that at lower age group, that's less than 20, the males overnumbered females in the lower age group, below 20. For between 40 and 60 years of age, females overnumbered males. So it means that whatever is being quoted as male to female ratio is truer for adult meningioma, not childhood meningioma. And that brings me to some of the differences between childhood meningioma and adult. There's a high incidence of tumors of the meningiomas of the lateral ventricles in children. There's higher incidence of cyst formation, and there is predominance of male to female patients in children, with 1/4 of the patients having neurofibromatosis, especially type 1. And in children as well, there's higher post-op recurrence compared with adults. Now, the incidence of the different locations is another point. In the paper presented by the presenters from Memphis, the paper on management of intracranial meningiomas, they found that olfactory group meningiomas were the commonest in the East. But in our own paper, we found that convexity meningiomas were the commonest in the West. That was UCH Ibadan. So is there any environmental or geographic variation with respect to the incidence of meningioma and meningioma types and location? That was the question we were querying in our paper. The other aspect that I want to touch on is about the treatment modalities. There are some novel treatment modalities that are based on molecular biology, based on genetics, based on epigenetics of meningiomas. And using the mechanism that regulates tumor formation and progression, a lot of treatment modalities have been proposed. Some people will call it maybe non-surgical management of meningiomas. Now, the candidates that presented last, as mentioned, observation, that's wait and see. We mentioned surgical resection, which is the most potent method of treatment of most meningioma cases, especially grade 1 meningiomas. When you get to grade 2 and grade 3, then variations of treatment begin. Now, we don't just continue to observe, but we need to continue monitoring progress during the period of observation by repeated cranial CT or cranial MRI to see whether the lesion is increasing in size and whether symptomatology is increasing. So though it's wait and see, we need to do something during that wait and see period. Now, surgical resection, especially Simpson 1, grade 1, is the best treatment modality that gives the lowest recurrent rate. Actually, with Simpson grade 1, we shouldn't expect any recurrence, but there are still recurrences that take place even after Simpson grade 1. Now, radiotherapy and radiosurgery are research for atypical and malignant meningiomas. Now, from radiotherapy alone and radiosurgery, we now have different factions of that. And I just go through them one by one, okay? Now you can use just radiation therapy alone as adjuvant for after subtotal resection or recurrence. But you can also apply stereotactic radiotherapy in form of external beam radiotherapy targeting a particular volume of the tumor, direct one. And then thirdly, gamma knife radiosurgery or stereotactic radiosurgery can be applied. These are some of the things that were not mentioned. Fractional stereotactic radiation therapy is another option. Fractional or hypofractionated stereotactic radiosurgery is either applied singly or in multiple doses. It's another option. Now that's for radiotherapy and radiosurgery. Now for chemotherapy, there are a lot of developments in this area. We know that most of the common chemotherapeutic agents, do not help in the management of meningiomas. But there are a few of them that have been particularly studied. Based on new molecular therapies or molecular findings in meningiomas, the first presenter gave us a lot on the molecular presentation of meningiomas. And most of these treatment modalities are targeted towards these genetic mutations, towards intracellular signaling, towards intracellular signaling pathways or methylation profile. Some of these are targeted against different subtypes of meningiomas. Now, there are therefore molecular biomarkers. The person mentions SMARCE1, SMARCE1 for clear cell, and BAP1, BAP1 for rhabdoid and papilloid subtypes, and so many other molecular biomarkers have been established. He already mentioned TAT, TERT, and then CNKN2A, and so on. All of these molecular foundations have been targeted with different types of chemotherapeutic agents. Now, we just mentioned a few of these chemotherapeutic agents that have been developed. We found that temozolomide, irinotecan, doxorubicin, adramycin, most of these drugs are not useful. They have not been found to be effective against meningiomas. But the first one that was first discovered was hydroxyurea, a ribonucleic acid reductase inhibitor. What it does is that it induces apoptosis and cell cycle arrest in the S phase. And so it's been used and tested and found to be effective against meningiomas. It's of moderate efficacy. Some moderate efficacy have also been found in the trial of cyclophosphamide, adramycin, and vincristine. All right. The other that have been targeted are these ones that I will be mentioning to you for convexity grade 1 to 3 WHO group. They mentioned the associated mutations and the target therapies that can be useful. For example, for convexity 1 to 3, sunitinib is one of the novel therapies. Everolimus octreoside, the octreoside that is used for Cushing's. It can be used for this same group of convexity meningiomas. Bevacizumab is another one for anteriorly based tumors or skull-based tumors. Everolimus octreotide is also useful for this one, and they've been tried. For central skull base, the most common one that has been used is bevacizumab. For spinal meningiomas, everolimus is also useful. Sunitinib is also useful. Bevacizumab is also useful. So there are so many of these drugs that have come out, and I think we need to be aware of some of them. Yeah, if at all you don't know anything about them, I just mentioned the names of these drugs that have been found as novel treatment modalities based on molecular biology, based on genetics, and based on epigenetics of meningiomas. The other area that I want to comment upon is the area of the occurrence per compartment. A simpler way of remembering, of course, is that 90% of meningiomas are supratentorial, about 10% are infratentorial. Now, for supratentorial meningiomas, 1/3 can be found around the superior sagittal sinus, that's parasagittal, and forks, 1/3. 1/3 convexity, and then 1/3 for basal regions like the sphenoid ridge, suprasellar meningiomas, olfactory groove, and tuberculum celli meningiomas, diaphragma cellar meningiomas. All of these form the basal region meningiomas. So it's about 1/3, 1/3, 1/3 for each of these sites that I've mentioned. Superior sagittal sinus and forks, convexity, and basal region. Then convexity meningiomas, parasagittal and forks meningiomas constitute more than 50% of all intracranial meningiomas. I think we should note that also. Then for surgery, I know it's been difficult to devise, to tell us all the different approaches to various locations of meningiomas. It might be very difficult. For olfactory meningioma alone, some will use bifrontal, some will use unilateral frontal, some will use subfrontal, and some will use keyhole subfrontal, and then some use endoscopic assisted subfrontal. So for just olfactory group meningioma, there are several approaches. And what determines which approach some people use or I use is the site where blindness is more severe. Maybe where visual loss is more severe, especially if one side has become blind completely. So you want to start from that side. If you are going to use a unilateral approach, especially if the tumor is located towards your right, and number one, and the blindness is more towards the right, you will definitely want to choose. If you are going to use unilateral approach, we use right unilateral approach. And number two is that one thing that was not emphasized during this lecture is about the visual loss that accompanies meningioma lesions. And we discussed this a lot in our paper that is talking about the factors that influence clinical and visual presentation in cranial meningiomas among Nigerians. We studied patients from 2020, from 2007 to 2017, a long period, about 22 years study. And we found that many of the patients were either blind or they have some visual impairment, or just a few of them, maybe 8% were normal, had normal vision. So we were wondering what could cause the visual loss in a patient that has infratentorial meningioma or someone that has periclinoid, meningioma, or someone that, meningiomas that are located very far away from the anterior visual pathway complex. Why should they have visual loss? We can easily understand why supracellular meningiomas will produce loss of vision with their compression of either the optic chiasma, the optic nerves, or the tract. But what about those that are convexity meningiomas that are far away? We discovered that we also related this to the size of the tumor, the site or location of the tumor, the whether the patient is old or young. We compared the age. We also use sex as a factor. We use tumor histology and then grade and type of tumor itself, whether it's a fibroblastic, whether it's syncytial or transitional, and all that. So at the end of the day, we also correlated our findings with degree of perilesional edema. Perilesional edema was graded into 3. The one that had no perilesional edema at all is grade 0. The one that had perilesional edema that is equal to the size of the tumor is grade 1. The one that has perilesional edema greater than the size of the tumor is grade 3. And then the one that, grade 2, the one that has perilesional edema that is holohemispheric is grade 3. We found that then we also added intracranial hypertension. Now we found that the visual loss was related to the size of the tumor greater than 3 centimeters. We found that it is related to intracranial hypertension, is related to the size of perilesional edema, and also related to the grade of WHO grade of the tumor. So we've definitely now discovered that definitely it's not just the proximity to the anterior visual pathway that is the cause of visual loss. It is multifactorial in origin. And the recovery of visual loss is also very poor after meningioma surgery. We found 2.9%, just one woman from the East. That was the project was at, the paper was written at UCH. One woman from the East, whether Owerri or Port Harcourt, right, was the only one that had a recovery of vision in one eye out of like 20-something that were either blind or severely visually impaired. At this point, I think I will stop. Maybe there will be questions to answer. Thank you.
Thank you very much, Prof, sir, for that overview. I've learned a lot, especially the rule of 1/3, and I think that will stick for most of us. I think today's discussion will also not be complete without hearing from a father of Nigerian neurosurgery, Professor Ohegula, who happens to be the founder of the Memphis Hospital for Neurosurgery, from where the presenters come from. I don't know if Prof is online. He has a word or two for us. Prof, sir, you're welcome, sir.
I enjoyed the presentations, even though I joined late. Struggling with my mobile phone, and eventually I uploaded to my laptop. Can you hear me?
Yes, sir.
Yes, Prof, we can.
Yes, we can, Prof. Thank you.
Yes. So it was only when I joined with my laptop I could meet part of Ogolo's presentation and Mwebueze's. I also enjoyed Debode's presentation. It's really a fantastic way to promote medical education. I think you said it all. Meningioma is a major problem. We thought it didn't exist. It's like gliomas we thought didn't exist. And early publications from Africa even Odeku's pioneering publications emphasize that meningiomas were the most common tumors in this part of the world. We're beginning to question that now because it looks like we're beginning to see more and more of other lesions. Of course, there are some that we know are rare, and we've drawn attention to this. And the challenge is to young neurosurgeons to add to the knowledge that is on the table at the moment. Are these speculations? Are they because people are not presenting? Or we can't blame diagnostic facilities now because we have more of CTs and MRIs in the country. So we should be seeing the pathologists. We should push for health insurance to make sure that those who can't afford paying from their pocket can benefit from medical intervention. And by this improving on funding on healthcare sector, we may be able to get more cases. Skull-based meningiomas are areas that are challenging, and we haven't seen much of publications. In fact, in a recent publication I was trying to do, I searched the literature, and the information available from Nigeria, as big as we are, and the rest of Africa was very scanty. So we still have a long way to go in mining epidemiological and other information on meningiomas. Let me use this opportunity also to announce that Surgical Neurology International is trying to launch, or has already launched, a digital version, SNI Digital, which is going to add value, a lot of help to medical education in neurosurgery. And the interesting thing is that this service is going to be free. It's just log on to SNI Digital, and you will be delighted with some of the information on some of the videos and lectures and lessons that will be available to guide you in your studies. Thank you very much. Let me not take more of your time. It was a wonderful, and I urge the to sustain this effort. Thank you.
Thank you very much, Professor, for the insights. We are grateful. I don't know if you have any question. On the chat box, we don't have questions, rather we have a request. Prof, somebody is asking for if you could have a link to your paper. So amongst those present, I can see some international faculty. We appreciate your presence, and we hope subsequent webinars will get to see more of you. In the absence of any question or comment, I think I create your indulgence, Professor, to call this meeting to a close. I see a comment here. So thank you everyone for coming today, and this academic gathering is adjourned till next month. Good evening.
Thank you for inviting me.
Thank you very much, sir, for gracing us with your presence.
Hello, sir.